Welcome back, everyone. We've just seen how to do a complex posterior leaflet repair and commissural repair. Now let's take a look at how we manage anterior leaflet disease, or flail, or prolapse. Across the STS National Database, it's considered slightly more complex to repair anterior leaflet disease than posterior leaflet disease, largely because of the excess motion and the chordal support that's required to restore the zone of coaptation. I'd like to show you some techniques that are ideally suited for robotic surgery on where we can repair and restore the zone of coaptation and taking, hopefully, what is deemed to be a complex problem with a fairly simple robotic solution. Let's get started. Well, as we increase in complexity together, some of the more vexing challenges we have in mitral valve repair surgery is the situation where we have an anterior leaflet pathology, particularly flail. This has a lower rate of successful repair in the STS database, but it does not mean that it's impossible. In fact, we would submit that one of the advantages of the robotic repair is to be able to visualize the subvalvular apparatus and convert a complex problem into a straightforward one. This is taking the robust secondary or tertiary fan cords and doing what is known as a chordal transfer. So taking it from a secondary position, which are usually healthy cords, and replacing the flailed primary cords with these robust fan cords using interrupted foro-monofilament suture, again, cardinal in this case, which does two things. It releases the restrictive component and allows successful mobilization in the primary component, followed by a circumferential rigid annuloplasty in this case, to create an excellent depth of coaptation, as we can see in the echo, and somewhat of a sail-like effect to not only avoid systolic anterior motion, but to create excellent competence. Now, what happens when you not only have a flail, but you have inadequate tissue to support? This is a somewhat complex and older patient who has similar pathology as the last case, but maybe a little bit more diffuse than the previous one. We've visualized, we've got a very nice, now it appears to be almost tertiary fan cord, and we've implanted this in the primary position, but it appears to be that there's more that will be needed, but let's have a look. So we'll do the first implant using the flailed segment as a handle. You can see my dual blade pulling that up on that view. Then trimming the flailed segment, which includes a little bit more than primary cords. And now let's see what else we can mobilize. Well, there's another one. There appears to be a somewhat decent fan cord, but probably not enough. So in this case, I've elected to combine the techniques and place a neocord using the same techniques we've described before and a double loop technique. The advantage here is that now we have a length that's predefined by the native cords. So it makes that previously challenging assessment of how long to make the cords now somewhat simple. In this case, my physician assistant is helping me with the placement of the suture fasteners and tying down the neocord to create an excellent coaptation without anterior prolapse. So now for another pathology, we have anterior leaflet flail, But in a setting of an unfortunate 76-year-old gentleman who had a GI bleed and heart failure, frail, somewhat emaciated, who had a Watchman implant, but at an outside facility where they did not do a TEE prior to implantation. And of course, the patient had significant anterior leaflet disease. But more importantly, the Watchman was also mal-deployed. So two issues. One is the diagnosis, and the second is the adequate deployment of the Watchman. You can see it's atrialized, and in fact, that actually can potentially be a nidus for clot formation in the setting of persistent atrial fibrillation, which this gentleman had. He was 45 kilos and quite frail. So a sternotomy in this patient would probably be challenging for his recovery. So after exposure, this is the technique of Watchman explant. Again, this is largely blunt dissection. As you pull these out, unfortunately, we've done quite a number of these, given the significant number of Watchman implants being done in the United States for a variety of reasons. And this one is just mal-deployed, so its initial implant was incorrect. Though it can be a very good procedure for the right patient at the right time, the important thing is to make sure we have the right diagnosis and there's absence of structural heart disease or coronary disease that would otherwise warrant a cardiac operation a priori. So this is bluntly taken away. You can see that the endothelium is incorporated into the fibrous body, but it's fairly straightforward to remove. Once it's explanted and delivered, then we now can fully inspect and make sure there's no trauma, no deficits, and no clot, which it appears to be. Now, what I'm demonstrating there is the proximity to the P1 annulus, which we'll comment in a moment. So now, as we've demonstrated earlier, we will now perform a full biatrial Cox maze. Let's not forget to treat why we're here in the first place. This patient had history of GI bleeding and anticoagulation he was not tolerant to. So while here, we'll do the full biatrial Cox maze, as we've demonstrated before, the inferior box line going into the left atrial appendage, the superior box line, the mitral line after placing the epicardial coronary sinus lesion, vertical atriotomy, tricuspid completion line, SVC line. By the way, you'll note that we don't snare the SVC and IVC by placing the venous cannula where we are. We can get excellent venous drainage without the need of snaring. In fact, we haven't snared in over a decade other than cardiac transplantation. So now we've completed the maze. And now let's put our left atrial appendage back together again. And it's important to note that despite the endocardial disfiguring, we should keep in mind what the actual anatomy is. So the first layer is done. There is some delamination of the endocardium, but keep the association careful to respect the circumflex territory and the P1 annulus. And this is closed in the fashion as we've already previously demonstrated with a two-layer imbrication technique to create a homogeneous and longitudinal closure. The patient had a patent foramen ovale with a shunt, and this is closed fairly simply with a figure of 8 cardinal suture. Well, now let's come back to what we came here for, is the anterior leaflet. We can see that there is fairly diffuse A2 prolapse and flail. More prolapse and flail, actually. I don't see any ruptured cords here. So the patient has some fairly robust secondary cords, a good fan there, but we might need more than one. And luckily, the patient has several to provide us. This can be facilitated by some upward traction It's very important here when you're mobilizing these secondary chords to not buttonhole the anterior leaflet by placing a hole in it from the ventricular side. So a little care is required. But this is one of the great advantages of robotic approaches, because you can look all the way in the outflow tract and do these types of additive repairs, which can be fairly difficult through a sternotomy and somewhat challenging through direct vision or videoscopic or endoscopic only assisted shafted instruments. So here we are. We've got several options now, and we'll reimplant these fan cords in the primary position through figure of 8 type of sutures, and do this in a stepwise fashion. One might ask, and this is the dual blade again, taking advantage, creating that exposure, again using the dual blade not just as a retractor, but as another hand, or in this case, 2 fingers. And now we've got that nicely secured. So one of the questions we often get is that how can you be sure those are robust? Remember, the robustness is required for presystole to assure that comes together in an adequate manner, because at mid to late systole, the anterior leaflet and posterior leaflet with coaptation are supported and become have decreased stress of the cord structures. And this gets to the Roman arch concept, where the 2 edges come together, and that's the stress point and not the cords themselves. So we really just need to focus on presystole to get the coaptation aligned and then the stress distributed. And this has proven to be quite a nice and adaptable technique that we've utilized for multiple years. In fact, we started doing this largely with our robotic experience over the last decade, fairly early on for these types of patients. And there we have now an intact valve. In this case, it supported by a posterior band, a 38 millimeter, fairly sizable. And there we have our completed mitral repair, Watchman explant, and biatrial Cox maze in a somewhat frail patient who did very well. Here's your coaptation depth. You can see there's again, that sail-like effect of the anterior leaflet with a good depth of coaptation and a completely obliterated left atrial appendage with a gradient of 2.
So now we've just seen how to repair anterior leaflet prolapse or flail in 2 techniques. One is chordal transfer, and one is when the cords themselves are not quite robust enough, and we support that with neocords. In our next episode, we're going to talk about now progressing to bileaflet disease and different techniques to approach this sometimes vexing problem.